Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight we will hear from Dr. Melissa Walker from Boston's Mass General for Children. Margaret Moore, UMDF Associate Director of Support and Education, will moderate the Q&A. For those interested in learning about what to expect at this June's UMDF Mitochondrial Medicine 2024 conference, we will continue after Dr. Walker's presentation to provide some insights as to what you'll experience while in Cleveland. But for now, let's get started with this month's Ask the Mitodoc. Take it away, Margaret.
I'm having some technical difficulties with my camera, but welcome to our May Ask the Mito Doc webcast. There I am. It took a while for me to pop on. I'd like to start by thanking our sponsors, Edith L. Trees Charitable Trust and UCB. Would like to remind everyone that the information provided in this webcast is for general information only. It should not be relied upon as a substitute for professional consultation with a qualified healthcare provider familiar with your individual medical needs. Please consult with your primary care physician or your specialist before you change the course of your care. Want to let everyone know that we have launched our latest version of our physician no cost genetic testing program. So if you or someone you know needs genetic testing, please visit umdf.org or use a handy QR code to scan and learn about our no cost genetic testing program. Attention all MELAS patients and caregivers. Please follow our MELAS stories at umdf.org/MELAS. But also, if you're interested in telling your story, please contact andy.dirth@umdf.org. That's Andy, our communications director. He'd love to hear from you. Have calling teens and tweens impacted by MELAS. Any adolescent from 12 to 17 impacted by MELAS can participate in this clinical research study. If you're interested, please visit umdf.org. The big news is that MitoMed 2024 is right around the corner. Please join us from June 26th through the 29th in Cleveland, Ohio. Again, you can learn more at umdfconference.org, or you can use the QR code and scan that now and learn more. Let's get started. Ask the Mitodoc, Mitochondrial Disease Primer. This is a guide for the newly diagnosed. Welcome, Dr. Walker.
Hello.
We're glad to have you here today, and this is such an important talk. For those of you that are in the audience, before we got started, I was letting Dr. Walker know that anytime a person is newly diagnosed, I will send a recording of this type video to them. So we're happy to be able to refresh those each year. And I'm going to let you take the floor and move on with your presentation. I will mute and stop my video, and we'll return for Q&A at the end.
Thanks so much, Margaret. Let's see if I can get this going and successfully launch my slides. Can you all see my slides? Oh, wait, there we go. Now can you see my slides? I hope.
Yes, perfectly.
Wonderful. Thank you. Good evening. My name is Melissa Walker. I am the director of the Pediatric Mitochondrial Disorders Clinic at Mass General Hospital in Boston. And it's a real privilege to get to be here tonight and speak with you all about a guide for the newly diagnosed patient. Some quick disclosures. You should be aware that I am an author on a pending patent application for a method to diagnose mitochondrial disease. I am a member of some of the organizations I'm going to reference this evening, including the Mitochondrial Medicine Society, and MGH is a mitochondrial care network center. I also have received research funding from many groups, including the United Mitochondrial Disease Foundation, the Child Neurology Foundation, and the NIH. And I have received honorarium in the past from the American Academy of Neurology. So this evening, I just want to emphasize it's amazing that the UMDF makes these recordings available to everyone after the fact. And I know this can be a lot of information and perhaps even a little overwhelming if you are coming to this new. So I encourage you, if you need to take a break, you will have the information available to you going forward. So what I'm hoping to do is first to discuss what mitochondrial disorders or diseases are and how genetic changes cause genetic mitochondrial disease. Then we'll talk a little bit about what questions patients and families should be thinking about for diagnosis and care. And while we will by no means be answering all of the questions that even we talk about this evening, hopefully I can point you in the right direction to get answers. And then also finally, to emphasize and outline some aspects of the community that is here to support you and point you again in the right direction for those resources. So with that, we'll start with what are mitochondrial disorders and how do genetic changes cause mitochondrial diseases? Now, whenever I'm answering this question of what is a mitochondrial disease, I kind of like to organize into three categories. And the first one is the clinical category. What signs or symptoms or medical problems do patients with mitochondrial disorders experience? And we'll talk a little bit about how patterns of those, when the same signs or symptoms group together, might be called syndromes. Then we'll talk a little bit about biochemical aspects of mitochondrial function and how that relates to processes that can be involved in the diagnosis of mitochondrial disorders, particularly the earlier processes that were first developed decades and decades ago. And then we'll talk about how what we've learned from some of those processes, as well as things we've learned with the new techniques, have really pushed us forward into this era of genetic testing, gene sequencing, which has taught us about a larger breadth of mitochondrial disorders, and which we now actually have as our gold standard for diagnosis. So starting with the clinical, what are mitochondrial disorders or diseases? So what I'm summarizing for you here in a cartoon format is a list of the many different signs and symptoms and medical problems that can be associated with mitochondrial disorders and diseases. These are not all of them, but these are kind of a sampling of the more commonly encountered problems. So starting with the brain, I am a neurologist, and it is because the brain can so commonly be affected in mitochondrial disease that neurologists like myself often choose to focus on mitochondrial disorders. Individuals may have stroke-like episodes or problems with coordination that we call ataxia. They can have seizures or migraines or other headaches, changes in their mental alertness states or developmental delay, or movement disorders such as dystonia or involuntary movements like chorea. The special sensory systems, which are closely tied to the brain, are often affected in mitochondrial diseases as well, and that can manifest as hearing loss or vision loss. Kind of keeping with the neurologist's purview, the peripheral nervous system can be affected, and that might lead to weakness or sensory changes in people who have mitochondrial disorders. We are increasingly recognizing, though, that other body systems can be very much impacted, including endocrine disease. So things like hypothyroidism or diabetes is actually a very common problem for people who have mitochondrial disorders. Also, liver disease or lung disease or kidney disease can occur. Gastrointestinal symptoms such as reflux or vomiting, diarrhea, or constipation, or in the most severe form, pseudo-obstruction can occur. And we know that muscles can be frequently affected in mitochondrial disorders. So if the skeletal muscle is affected, that can manifest as what we would clinically call a myopathy and would lead to potentially having weakness or fatigue or exercise intolerance. And the heart, we know, is a muscle as well. So difficulty with the mitochondria in the heart can cause heart disease, or even abnormalities of the electrical signals the heart sends and cause things like arrhythmias. So all that to say, no single symptom confirms a diagnosis of a mitochondrial disorder. And as we'll discuss in the next couple of slides, there are, however, some patterns that we can help point us in that direction. As you can see, because almost every cell in our bodies have mitochondria, symptoms of mitochondrial dysfunction can affect almost any body part or organ. So it's not surprising, especially after that list I just gave you, that an average mitochondrial disorder patient can have up to 16 different medical problems or conditions. But getting back to this idea of patterns and clustering of signs and symptoms, when that happens, often clinicians will recognize the pattern and describe it as what we call a syndrome. And I'm going to highlight some syndromes today that are among the more common mitochondrial disorder syndromes. And we'll start with Lee syndrome. So Lee syndrome is actually the most common manifestation of pediatric mitochondrial disease. It can, however, be caused by damage to one of over 80 different genes that we know of to date. And any individual with any different type of damage to one of those genes can have this similar cluster of symptoms. And that will include things like an abnormal brain MRI, developmental delay, movement disorders, particularly dystonia, and sometimes encephalopathy and apnea. These patients can also have myopathies and heart disease, or any of these other symptoms that I just described, but not necessarily any particular one or any particular list of them. It, as you can see, can be highly variable how an individual is affected with this disease. Now, moving on to another mitochondrial disorder that is actually one of the more common forms seen in adults, we have mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes, or MELAS. MELAS is a little different, genetically speaking, from Lee syndrome in a couple of ways, and one of them is that most people who have MELAS have the same gene change, or what we call pathogenic variant, or used to call mutation. People affected with this syndrome will have, by definition, stroke-like episodes and or seizures. They will also often have hearing loss and diabetes, quite commonly, as well as myopathy, but they also can have heart disease or endocrine conditions. And again, there can be a lot of variability even between two people who are related, who carry the same gene change. And moving on to our third and final syndrome, I'm going to now kind of contradict what I just told you, that individuals will more often have a whole variety of symptoms affecting different organ systems. It does turn out that there are some mitochondrial disorders that will affect one system primarily, and almost uniquely or solely. An example of that would be Leber's hereditary optic neuropathy, which is also a relatively common mitochondrial disorder among the adult population. And individuals affected by LHON will typically have vision loss, but not necessarily these other symptoms that I've described. So taking that together, the big take-home point is that every mitochondrial disorder is different, and this makes them very difficult for doctors and other providers to diagnose. Each patient is unique, even within the same family. So having the same gene change and even being siblings might not mean that two people will have the same experience of a mitochondrial disorder. And for that reason, it is exceedingly difficult to prognosticate, i.e. to tell patients what they might expect in the future. We do our best, but because mitochondrial disorders are rare, even the studies where we might have retrospectively or after the fact looked at what happened to a large group of patients are very difficult to do. So it's very hard for us to know. We also don't have lab tests that can predict outcomes for us. So we are still very much learning in that space and trying to move that research forward. And that highlights another point that I think is very important to make, and you'll hear me make a couple times in this presentation, which is that information about one condition or even one patient does not necessarily apply to another. So we all as providers and as caregivers and as patients have to be very careful in taking information about one disease or diagnosis or one individual and making conclusions about what might happen to someone else based on that information. So now let's move on to kind of the biochemical category. Let's talk a little bit about what we know about how you get from all of these symptoms to mitochondria and back again. So we have the human body. We have all these organ systems, and I've put this cartoon on the slide for you right off the bat. But what I've presupposed is that you'll remember that our bodies are composed, every single organ and tissue, of cells. The cells are the fundamental unit of multicellular species like ourselves. And you have to look under a microscope to see a cell. And if you look under a microscope even larger at a cell, what you'll see is that there are substructures or smaller pieces within our cells, and each have their own intended function. What I'm showing you here in this cartoon is a cell with our mitochondria drawn in it. And what we've known for almost 100 years now is that those mitochondria have a very powerful set of proteins in them that make something we call ATP. Now, why am I bringing this up? Why this molecule? ATP is the currency, the IOU that one part of a cell sends to the other to transfer energy, or that two cells exchange with each other to transit energy and signals. It is how the work of the body gets done. And that's why you've probably heard mitochondria described as the powerhouse of the cell. And we've known that, as I said, for almost 100 years. But what we've learned since that time is that's not all that mitochondria do. They carry out a myriad of metabolic reactions. They break down fatty acids, they break down protein into amino acids, they make vitamins and they use vitamins. They do detox reactions. So if you, for example, have been told by your doctor that a medication is metabolized by the liver, that's your mitochondria in the liver breaking down the medicine after it's done its job. Mitochondria, we are increasingly realize, also help different parts of the cell talk to each other and communicate what needs to be done next. And they can also help two different cells talk to each other. And we see that most prominently recently in immune signaling, where cells in our body have to talk to each other to fight an infection. So they also, importantly, we know, are involved in checkpoints that tell our body when a cell needs to be started over, when it needs to undergo what we call programmed cell death and apoptosis. So when these processes were first discovered, some very astute physicians and scientists theorized that if this electron transport chain that makes ATP was broken, that could cause human disease. And when the first mitochondrial disorders were described back in the 1920s, they were indeed diagnosed using biochemical tests. And let me talk quickly just maybe about two of these. So I will start with a more recent test that you've probably heard of, blood lactate. So blood lactate is a great example because many individuals who have a mitochondrial disorder will have high lactate levels. But high lactate levels can be caused by many things, including things like sepsis, which is a severe infection, or very rigorous exercise. The older test that I'm showing you in its newest form or cartoon representation of is something called spectrophotometric analysis. And that is about as complicated as it sounds. That involves taking a small piece of tissue that we've obtained by biopsy, usually from skeletal muscle, but could also be from the liver or somewhere else. And we have extracted the mitochondria from that small piece of tissue. And then we shine UV light often through a liquid suspension of those mitochondria and use the signal changes in that light pattern to determine how effectively certain reactions that the electron transport chain carries out are happening. As I said, this is as complicated as it sounds, and what we found is that it's not always going to pick up every person who has a mitochondrial disorder that affects this electron transport chain. It's also not going to pick up people who have damage to genes that do other things in the mitochondrion. And finally, also important, it's not sensitive to the cause of the damage to the electron transport chain. So if an individual has mitochondrial dysfunction that they got from an infection or an autoimmune disease or downstream from another genetic disorder that led to increased wear and tear, shall we say, on the mitochondria, there will be no way of telling the difference between these. So for that reason, in order to capture all of these other disorders that we know won't show up on these types of tests, and also to get a better sense of the first starting point of any given mitochondrial disease, we now recommend genetic testing as the gold standard for diagnosis of a genetic mitochondrial disease. Now, what do I mean by that? Genetic mitochondrial disease. So you're probably already familiar with the notion of DNA and inheriting DNA from parents, but I'm going to draw a cartoon and put us all on the same page here. So each of us has nuclear DNA, which is probably what you're thinking of when I say DNA. That's the 23 pairs of chromosomes that we each have. And I'm drawing only one pair here with each person to keep the cartoon simple. But each of us has inherited one half of a chromosome pair from each parent, one from our father and one from our mother. Now, what's less commonly known is that our bodies actually carry two types of DNA. So in addition to the nuclear DNA, our mitochondria have their own DNA. And because we only get our mitochondria from our mother's egg cell, we only get our mitochondrial DNA from our mothers. So while a mother can pass on mitochondrial DNA to her child and also half of her nuclear DNA, a father only passes on half of their nuclear DNA and not their mitochondrial DNA. So the fancy way of saying this is that mitochondria are made from two genomes. And what do I mean by that? I mean that we get genes from the nuclear DNA and from the mitochondrial DNA, and our bodies put them together to make a mitochondrion. And this is a fancy cartoon put together by my colleague, Dr. Rohit Sharma, and he's actually listed out here all of the about 1,100 different genes that we know are necessary to make a functioning mitochondrion. And what we also know now is that about 300 of those genes, if you damage them, will cause mitochondrial disorders in a genetic mitochondrial disorder. Now, put that simply and kind of run through the numbers. We know that we have a total of 60,000 genes encoded by our nuclear DNA and only 37 encoded by our mitochondrial DNA. Of those 60,000, 1,100 or so are needed to make a functioning mitochondrion, and all 37 of the mitochondrial genes are needed. And among each of those gene sets, about 300 and counting have been associated from the nuclear genome with human disease. And 37, of course, have been associated with mitochondrial disease from the mitochondrial DNA. Now, I've raised this issue of a genetic mitochondrial disorder. What else could look like a mitochondrial disorder? What else might cause that damage to the mitochondria that could produce similar symptoms? Well, there are other genetic conditions that can look very similar. I told you that there were 60,000 genes in our nuclear DNA, and many of them can produce diseases that have similar presentations. Infections, as I mentioned, particularly chronic infections, can mimic mitochondrial disease. And rheumatologic or autoimmune diseases can as well. And all of these processes can cause what we call secondary mitochondrial dysfunction without ever disturbing or damaging the genes that work inside the mitochondria themselves. So you might ask, what do you do if you have symptoms, but you don't have a genetic diagnosis? And the first thing I'll tell you is that there are experienced physicians who can diagnose mitochondrial disease based on a combination of clinical features and laboratory findings and imaging findings or other studies to take the preponderance of data and say this is the most likely answer. But for some patients, a different cause may actually be identified, whether it is infection or autoimmune disease or a different gene change. However, even in spite of all of the advances we have in all the fields of medicine today, there will be people who do not receive a diagnosis. So what do you do next then? Well, if you've had thorough genetic testing and it's negative, you should talk to your provider, and you may want to consider further genetic testing, either with different techniques or different tests, or reanalysis of the same testing in the future. And I'll point out that about every 2 weeks, a new gene disease association is discovered. So there's always utility to revisiting this conversation with your provider. Okay, so now we've reviewed kind of how genetic changes cause mitochondrial disease and talked about what that is. Now we're going to talk a little bit about the questions that families and patients might want to be thinking about with regards to diagnosis and care, and discuss where you might go to get answers. We'll begin by talking about inheritance risk, since we just finished talking about genetics. So as I mentioned, we have these two genomes. If a mitochondrial disorder is the result of a genetic change in one or the other of these genomes, family members and future pregnancies or children may be at risk. And it's really important that you talk to your provider about your specific condition, because everyone has its own nuance and differences in what the risks would be. In particular, we would recommend that you ask your provider or genetic counselor to discuss with you what those risks would be to other family members and any future children. For future children, in particular, what you would request would be preconception counseling to help you understand the risk of a future child being affected by a disease or passing it on themselves, and talk about what options you might or might not have to modify that risk. Now, moving on to symptom management and treatment. Unfortunately, the first thing I have to say on this is that there are currently no FDA-approved targeted treatments for genetic mitochondrial diseases. There is, in a way, one exception if you consider Friedreich ataxia a mitochondrial disorder. Friedreich ataxia does now have an FDA-approved targeted treatment, but no other mitochondrial disorder does at this time. So in most cases, medical problems that patients with mitochondrial disorders have are treated per standard of care. But that's most cases, and there are important exceptions So again, you should always talk to your provider, let them know about your diagnosis before you receive any care for a medical problem. You may or may not have heard of mitochondrial or mito cocktails. So the first thing we'll say about these is that they are not scientifically proven. We've unfortunately never been able to have the kind of uh, placebo-controlled clinical trials that we want for medications when we want to prove that they work. So for that reason, what you'll find is that prescribing practices vary. Different doctors in different institutions and even different doctors at the same place might prescribe their mitochondrial cocktails a little differently. Um, but generally speaking, most providers will offer them, but you should be aware that the cost of these are typically not covered by insurance because they are over-the-counter supplements and not considered to be medication. You can find more information about mitochondrial cocktails at this link, which is an NIH website. And I will also point out that clinical trials are very much underway. I led by saying we have no proven therapies, and I will end this slide by saying that we are working very hard towards getting there. So the flip side of the coin with treatment is what treatment should patients with mitochondrial disorders not receive? So I'm going to make the same disclaimer many times, but talk to your doctor about your individual circumstances always, because every mitochondrial disease can be different, and the medications to be avoided in any given mitochondrial disease will vary significantly between diseases and given individual circumstances. Importantly, if you Google this, you will find big, long lists of medicines that people with mitochondrial disorders shouldn't take. And these are outdated. These lists predate a lot of the better scientific knowledge and the longer clinical experience we now have. I would recommend that you refer your provider and look yourself at the list available at this link from the Mitochondrial Medicine Society. I will, however, point out one important medication to be aware of in a few classes. So Depakote or Depakine, which are valproic acid derivatives, which can be used to treat seizures or headaches or mood disturbances, are absolutely contraindicated in individuals with Polg-related disease in most circumstances. And given, depending on the mitochondrial disorder being considered, some antibiotics or antibiotic classes should be avoided. Some medicines we know that are given commonly to the broader public can increase lactate levels. So we are always cautious in giving these types of medications to our patients who might be at risk of having higher lactate levels themselves. But these are what we call risk benefit analyses. So we have to sit there and decide whether the risk of the side effect of the medication outweighs the benefit that it might have. Similarly, there are medicines that are prescribed commonly that can worsen muscle weakness or nerve function. And again, these are all kind of risk-benefit decisions that you make with your provider. And I'll just point out that there are medicines that you shouldn't take if you have a specific medical problem. For example, acetaminophen shouldn't be taken in large doses by people with severe liver disease. And that's the case whether the liver disease is caused by an infection or a mitochondrial disorder. So next, let's talk a little bit about diet and nutrition. People will also often ask, is there a specific Mito diet? And the answer is no, no specific diet. And yes, talk to your provider. And I will add that patients may benefit greatly from seeing a nutritionist or dietitian, particularly patients who have difficulty maintaining a healthy weight. Some patients will respond better to small, frequent meals throughout the course of a day. And some patients really need to avoid fasting. And again, these are important topics to talk with your doctor about, questions to raise. The next topic I want to talk about is exercise in mitochondrial disease. And again, We're going to lead with the disclaimer that you should always talk about your individual circumstances to make sure exercise is safe. You may, depending on your circumstances, need to see a cardiologist or have certain evaluations before you start an exercise regimen. But we bring the topic up specifically because, in general, exercise is recommended and felt to be beneficial in mitochondrial disease. We always say, listen to your body, stop and rest when you need to, and always make sure you're getting adequate hydration. This is important at all times, but particularly if you are exercising. And once you have a clearance from your physician and you've made sure that you can rest and stop if needed and hydrate well, consider both resistance and aerobic training because both types can be beneficial in the setting of a mitochondrial disorder. One important thing to think about is that children who are in school may benefit from individualized plans or 504 accommodations to modify physical education classes at school or even substitute physical therapy for these classes, depending on the circumstance. And you can find more information on this topic at this link to the UMDF website. So moving on, emergency care is something really important that your provider is going to discuss with you if you have a mitochondrial disorder. Metabolic stress can worsen health or medical problems in patients with mitochondrial disorders. And those metabolic stressors include things like infection, fever, dehydration, starvation, or surgery. And not every physician or medical provider you will meet or encounter has deep knowledge of mitochondrial disorders. Some may not even be familiar with them at all. And that's why it's really important to ask your doctor for an individualized emergency or acute care plan. So what we typically recommend is giving the patient a copy, electronic or paper, that they themselves keep and have access to at all times, wherever they may be going. And of course, also a copy in the patient's chart. And many electronic medical records these days actually have a function where these types of acute care plans can be pushed to the screen immediately when a patient arrives in the emergency room or point of care. Children's Hospital of Philadelphia, my colleagues there have developed an amazing resource that you can access online and share with your physician to develop a plan. And it can be found at this link. Another important topic to consider is what to do if you are planning to undergo a surgical procedure or anesthesia for some other reason. So now, in these circumstances, it's an important time to ask your mitochondrial provider to collaborate with the anesthesiologist or surgeon prior to the procedure. And they'll come up with a plan together. And that plan may include things like a method to make sure that you have adequate energy before, during, and after the procedure. Similarly, to make sure you or your loved one has adequate hydration before, after, and during the surgery. And also make any necessary provisions for extra monitoring that might be needed at or around the time of surgery. So another important topic to talk about is health insurance. And when you are arriving at an important medical diagnosis like this, it's always good to understand your insurance plan and your options. And here I'm going to highlight that secondary insurance or supplemental plans can be really helpful to many families. They may be Medicaid versus Medicare, and many states, most states will actually have plans specific for children with complex medical needs. And many of these will not necessarily have an income cap and may be purchased on a sliding scale. So ask your providers and your social work team about these options and research them yourself online. Should also be aware of any predetermination and explanation of benefits associated with your insurance. And One great resource can be insurance case managers. Oh, excuse me. And these are individuals who can help you understand your plan and help facilitate prior authorizations and referrals as needed. Okay, so at this point, I want to pause for a moment and talk about where to get support. We've just talked about a lot of technical, medical, and scientific information and details about hospital plans and insurance, but what I want to focus on now is receiving this diagnosis and how to find support. So no two individuals' experiences are, of course, are the same whenever someone receives a life-altering diagnosis. And we have seen that patients and loved ones can have variable responses. There is no right response, there is no wrong response. Typically, of course, we all worry about our children or loved one or our own futures when we are affected by a medical condition. A patient or a caregiver may feel burdened with responsibilities, including all of the things I've just itemized for you in the slides before this. They may feel pressure to become an expert in mitochondrial disease or have difficulty balancing all of the day-to-day tasks that they had already before, and now the added strain of making doctor's appointments and checking for that prior authorization and figuring out who the right person is to be referred to. And that's on top of having perhaps other children and other responsibilities, both at home and at work. Some people will be very open about this and able to discuss it, and some people are going to be a little less inclined to talk about it. And this can all lead to stress and potentially even distress about medical and financial uncertainties. And of course, whenever we have big stressors like this, we can all develop problems such as stress and anxiety that can affect both our personal and our work lives. And for that reason, and keeping that in mind, we want to emphasize that if you are feeling overwhelmed, there are people to help and you should reach out to them. If you are a caregiver for a patient, remember that you have to take care of yourself as well. The whole allegory of putting on your own oxygen mask before you put on the child's mask next to you. It is important to keep yourself well so that you can be there for everyone else too. So if you have red flag signs that persist, such as trouble sleeping or difficulty controlling or stopping negative thoughts, if you lose your appetite or more irritable than you think you should be, or are engaging, you think, in excessive alcohol use or other reckless behaviors, or having thoughts of worthlessness or life not being worth it, please seek help. Professional help can benefit anyone in these circumstances and prevent serious problems from developing and empower us to address the challenges we face. And as I mentioned, you are not alone. There is a community here to support you. And we are only beginning right now to understand the impact that these type of stresses have on patients and caregivers in our mitochondrial disease communities, especially when caregivers might be at risk of being affected themselves by the medical condition in question. So how do you access these communities? How do you find this support? The United Mitochondrial Disease Foundation, as you've already seen, is a great place to start. Other organizations such as Mito Action are also amazing resources, and many others, more than I can list on a single slide, some of which are focused on specific disorders, some of which are focused on specific regions. They're all out there, and they can provide you with additional information, guidance, and resources on their websites or through their staff. And of course, many people find it incredibly rewarding to attend these regional or national symposiums, such as the UMDF annual meeting that's coming up in June in Cleveland. And finally, of course, joining online support groups has been a real boon, I think, to many patients and communities. But let's talk about support group forums. So they can be an invaluable resource for advocacy, for recommendations on providers and services and patient resources. But again, keep in mind, no single person's experience is universal, and what you may hear one person going through may not be true for you. Therefore, also, some medical advice that you might hear may not be applicable to the condition that you or your family member or loved one has. And in some cases, interventions that one patient receives and is beneficial for them may actually harm another. So it's always really important to talk to your medical team and make sure that any advice you get makes sense for you or your loved one. Well, I keep referencing this medical team. How do you find this medical team? How do you find a mitochondrial medicine expert? And I've highlighted for you here two groups that we have here in the United States, the Mitochondrial Care Network and the Mitochondrial Medicine Society. So the Mitochondrial Care Network actually organizes and certifies academic centers of excellence for treating mitochondrial disorders. And the Mitochondrial Medicine Society is a group of physicians who all focus on patients with mitochondrial disease. We are often geneticists or neurologists. As I mentioned, it's kind of an accident of history that because so many of these diseases have such profound neurologic symptoms, they were often first diagnosed and then continued to be diagnosed by neurologists. So we are, as a group, a big part of the mitochondrial medicine team. And geneticists, of course, diagnose genetic conditions, and many of them, we are very fortunate, choose to focus on mitochondrial disorders. Experts in mitochondrial medicine can help you confirm a diagnosis if it's been suspected by another provider. And we can proactively screen for medical problems. We can look and make sure that a patient isn't developing heart disease, or if they are, find them the right doctor to help take care of them. We can help you to the best of our ability in knowing what to expect. We can guide you in the type of care you should anticipate needing and how to identify the right teams and places to get that care. We can help you, as I mentioned before, predict the risk for other family members and for future children. And we can be a link to research studies, including clinical trials. But we don't do it alone. A Mito medical care team is a team, and that should be with a capital T. So on your team, you will have a mitochondrial physician, a geneticist or a neurologist, as I mentioned, and you will have your primary care provider. This person is an incredibly important part of your team. You need a primary care provider who is experienced in taking care of patients who have complex medical conditions, who see multiple specialists, and a person who is good at communicating with those specialists and facilitating all the care that they will recommend and be collaborating with that person to provide. As we mentioned earlier, a genetic counselor is a big part of the mitochondrial medicine team. And if you have cardiac disease, a cardiologist, or if you have gastrointestinal disease, a GI doc will be important team members. I strongly encourage patients to see dietitians and nutritionists, and of course endocrinologists if there is a need. And one specialty I'd like to highlight today is physical medicine and rehabilitation, or PM&R, also known as physiatry. They are a lesser known subspecialty, I think, but they are an amazing group of physicians who are able to help patients optimize their independence, whether it be with mobility or fine motor skills, and they can give our patients so much with their care. And they work typically in collaboration with physical therapists and occupational therapists and speech therapists. And I also have to put out there that psychologists and psychiatrists are often key members of the team, as are social workers. So some other resources that I want to put on your radar to be aware of. For pediatric patients, early intervention services before the age of 3 are going to be the first backbone of the services a child will receive if they have a diagnosis like this. After age 3, you transition to the school system, and you should be aware of certain things such as Section 504 of the Rehabilitation Act of 1973, which guarantees a free and appropriate public education for students kindergarten through 12th grade. And then in the 90s, the individualized education plan became mandated. So each student is required to have an individualized education plan to help them optimize all of their studies and functioning. And you can find details about this and other details at the ada.gov website that I've listed here. Now, from a care provider point of view, it's really important, of course, to know about the Family Medical Leave Act, or FMLA. And this guarantees up to 12 weeks of unpaid leave with job protection at companies with 50 or more employees, and if you've been employed at that company for more than 12 months. Also important to know about are Social Security and disability insurances, both the Social Security provided by the government as well as private disability insurance. Each of these options that I've listed here by their acronyms are things that might be worth investigating and learning the nuances, in particular for adult children who have acquired a disability before the age of 22, and what benefits they may or may not be eligible to receive at different times in their lives. So I feel like at this point, I have talked a lot about some of the things we wish were different and the things that we know we have to do to improve care and lives in patients. And I want to end on a note of optimism and highlight the research that is actively being done to come up with therapies and to improve the lives of patients and families. This is a chart I put together about once a year, every year, of all of the clinical trials registered in clinicaltrials.gov. And when I first started making this chart, it didn't fill nearly as many rows, and there was barely a need to have all 4 columns for the different phases. And what you can see now is that there are many clinical trials underway, which I personally take a lot of encouragement in. And if you are interested in research or in clinical trials, I strongly encourage you to check out these websites, clinicaltrials.gov and the UMDF website, the Mito Action website, and the NORD website, where you will find all of the available research studies. A couple of important notes about research, though. First and foremost, research is always voluntary. You never have to do research or participate in research in order to get medical care or anything else. Second, again, talk to your expert providers and your doctors whenever you're considering a clinical trial. I personally strongly encourage my patients to make sure that if they are part of a clinical trial, that it's being performed at a reputable academic medical center or other institute that would be governed by an institutional review board and follow all the best practices scientifically and ethically for research. So I will end there, and thank you all for your time and your attention, and take any questions.
It seems to be taking a minute for my video to turn back on, but thank you so much. That was absolutely amazing. I learned a lot, and I have a few questions for us to run through real quickly. I want to get started by I summarized some, took some from the chat, and took some from that I've received just over time from our patient community. one of the ones that came right from our Q&A feature was, do any of the amino acid depletion syndromes cause mitochondrial disease?
Oh, that's a great question. I understand that question as um, a genetically encoded
Yes.
acid. Okay, so we do think that there are patterns suggestive of secondary mitochondrial dysfunction in many of these disorders. And we think that because of some of the lab abnormalities we can see, and also because some of the clinical symptoms look like clinical symptoms of mitochondrial disease.
Oh,
That's
thank you. That's a perfect answer because it leads into another question I have. Acquired and secondary mitochondrial dysfunction. How is that different from mitochondrial disease, and would the treatments be similar?
that is a great question. So, as far as how is it different from, I suppose that depends on who you're talking to and how they're defining mitochondrial disease. And in this talk, I was working primarily on the assumption that we're defining mitochondrial disease as genetic mitochondrial disease. And if we are, then the difference is in the cause of the damage to the mitochondria. In a genetic primary mitochondrial disease, the mitochondria are damaged because one or more of the genes that we need to make the mitochondria is damaged. In secondary causes, it's happening because of something else. And in these circumstances, I wish I knew more about cars to make a good analogy, but it's like your brake pads wear out, and because of that, the tires get bad. That's probably not actually very accurate analogy, but that some other part of the cell or the body uh, isn't working properly, and it in turn produces wear and tear and damage on the mitochondria. And then as far as treatment, that is both a difficult and an easy question. I suppose it's easy, unfortunately, in that we don't have targeted treatments for mitochondrial dysfunction. So many doctors will prescribe mitochondrial cocktails for secondary mitochondrial dysfunction, but we don't have any proven therapies, and any symptom attributable to mitochondrial dysfunction, either primary or secondary, whether it would be heart disease or seizures, would be treated more or less the same way that heart disease or seizures caused by some other condition would be.
Wonderful. Thank you. Then the next question. I think I benefit from CoQ10. Why can't they show that it's effective?
That is such a good question, and it's such an important one to talk about. So the reason is we haven't done the right clinical trial. Now, different people will tell you different reasons why we haven't, but there's many. So as this audience is well aware, mitochondrial diseases are rare, right? Getting enough people together to have a large enough group to say for sure something helps, that's problem number one. And then, as we just discussed, every mitochondrial disease is different. So it might be that CoQ is helpful for mitochondrial disease A caused by gene A, but mitochondrial disease B, it doesn't help that much. But we can't even know yet because we don't have enough of A or B, or even A and B together, to do one of these clinical trials. And three, there are all of these difficulties in launching any clinical trial. So you have to have the money to pay the people who will study and enroll patients. You have to have the money to provide the medication that you're testing. So where does that money come from? The other problem is with things that patients can already purchase themselves. It's often difficult to say, okay, I'm willing to stop my CoQ, even though I know it's helping me, so that I can be the placebo group. That's, sometimes a hard sell for patients, which is understandable. And for that reason, and because we know things like CoQ and these other vitamins and supplements that we use typically are safe, we as physicians go ahead and recommend them, even though we can't prove that it's going to help.
Right. Well, that's very helpful. Can hormonal changes cause worsening symptoms in patients with mitochondrial disease? And what should you do?
Oh, that's a great question. So The answer is probably yes. I don't know, to my knowledge, of any rigorous studies looking at hormone changes and the effect on mitochondrial function in patients, but we do know kind of the opposite of that, which is some patients with mitochondrial disease can have precocious puberty, or they can have ovarian failure, meaning that their ovaries are not functioning properly. We also know that hypothyroidism can occur in mitochondrial disease. And we know from basic science that typically when a cell encounters a hormone, there are changes that consume energy. So it would stand to reason that that could be an aggravating factor. Now, as far as the what should we do about that, again, that's going to be very case specific and a good discussion to have with your mitochondrial expert and probably an endocrinologist.
Very good. Can specific medications cause muscle weakness in patients with mitochondrial disease?
Yes, they can. And as we discussed on the slide about contraindications, these are relative. So one famous example of a medicine that can cause muscle damage or weakness by ways it interacts with mitochondria in any person is statins. So a commonly used lipid-lowering drug. So many doctors are very careful with giving statins to patients. Well, we're all very careful for giving statins to patients with mitochondrial disease. And in some cases, we won't give it because we are concerned that it could worsen muscle weakness in a patient. That's just one example, and it's all going to be weighing the risks and the benefits.
I have one more question. What makes you the most hopeful for the future for people with mitochondrial diseases?
Well, I would have to say two things. I'm going to cheat and give two answers.
You can. It's okay.
So first, but not most importantly, I would say we are living through a really exciting time technologically. I would consider myself to be a middle-aged doctor. It wasn't that long ago that I was in medical school. And when I was in medical school, I would never have dreamt that we would have gene therapies for anything, period. That we would have all of, enzyme replacement or any of these therapies that we know now exists and are such powerful, wonderful treatments for other disorders. And I have great hope that some of these technologies can be brought to bear in Mito space. But two, and even more importantly, it's this amazing community of patients. It is the families that I see not only manage to live with medical problems and get through every day, but then advocate for research and participate in research. And it's an incredible community, and that's what's really going to push the field forward. It's the patients and the patient advocates and the families.
Oh, well, thank you so much, Dr. Walker. This was great. I can't wait to send this presentation out to our new families so that they'll really feel supported right from the get-go. So thank you so much. I want to give a reminder that if your question wasn't answered today, that we will be holding those questions for next month's Ask the Mito Doc webcast, which will be on Thursday, June 27th, 2024. A little different time here from 4 p.m. to 5:30 p.m. Eastern time. This will actually be a live broadcast from our conference. And Dr. Walker is one of our panelists. So everyone mark your calendar for Thursday, June 27th, 2024. Dr. Walker, we're looking forward to seeing you there. And again, want to thank you for a very complete and very clear presentation. Like I said, we'll use it for months and years to come.
Thank you all so much for the invitation. It's a privilege to be part of this.